Good morning. Today we shall discuss a short discussion on IEM and its management. As an introduction, IEM is in fact reported in about 30% of patients undergoing manometry. In fact, the incidence is much higher in some other places. However, there seems to be no clear clinical significance and management with regards to IEM. IEM is usually not associated with any symptoms or esophageal diseases. It can also be seen in asymptomatic healthy individuals. The definition of IEM in Chicago 3 requires more than 50% of ineffective swallows with a normal IRP. However, in Chicago 4, the criteria for definition has been tightened, where we require at least more than 70% of ineffective swallows or at least 50% of failed swallows. In fact, further characterization with specialized maneuvers during manometry, for example, multiple rapid swallows, solid test swallows, solid test meal, would assist in characterizing or delineating IEM further. There is no specific management to reverse the motor pattern of IEM. The management, in fact, revolves mainly in improving reflux-related symptoms. Impedance and also FLIP can define the pathophysiology and segregate IEM into its phenotypes. However, this modality requires more data and more evidences in the future. These are among the provocative tests that can be performed to augmentate the features of IEM on manometry. Moving on towards the pathophysiology of IEM. In fact, IEM can broadly be divided into neural factors and also muscle dysfunction. The neural factors can originate from central or peripheral causes. With regards to muscle dysfunction, it can originate from a primary muscle dysfunction, or in fact, it can also be caused by GERD, medications, or even other causes. And when the patient develops IEM, the sequelae or the consequences, in fact, in some people, it can also be a normal variant. In some situations, patients may be asymptomatic. However, some patients may experience abnormal reflux clearance. Some may also experience abnormal bolus transit. Briefly, we have two types of peristalsis, the primary and the secondary peristalsis. The primary peristalsis in the esophagus involves both the skeletal and the smooth muscle, and this is dependent on the impulse from the brainstem nucleus. Secondary peristalsis in the esophagus, in fact, is triggered when there is esophageal distension, and this contributes to at least about 90% of reflux clearance, especially during sleep. However, secondary peristalsis is affected by impaired muscle contractility, sensory and motor defects, aging, and also reflux. Well, if you look at the diagnostic approach of IEM, when there is impairment of the primary peristalsis, the ideal test would be performing a manometry. And subsequently, if the patient has dysphagia as the predominant symptoms, we can perform a solid test swallow or viscous swallow with RDC or even a meal test. On the other hand, if reflux is the main predominant symptom, we could perform multiple rapid swallows and monitor them post-MRS. If the patient, in fact, is planned for an anti-reflux surgery, the patient would have to undergo a multiple rapid swallow and also an RDC. FLIP, on the other hand, the data seems to be limited, and in fact, we need more evidence in the future. Well, FLIP can be used to elicit secondary peristaltic responses, where we can measure the luminal diameter changes along the length of the balloon. However, as what mentioned earlier, the evidence is rather limited. With regards to IEM and pH study, severe peristaltic dysfunction, for example, more than 70% of ineffective swallows, is usually associated with abnormal acid exposure and esophageal mucosal injury. However, despite the fact of the association between IEM and abnormal reflux monitoring, IEM is in fact not pathognomonic for the presence of reflux. So based on these concepts, the primary indication for reflux monitoring in IEM is mainly to establish or exclude the presence of reflux. It's not meant to diagnose IEM. Well, when we look at clinical implications, IEM in fact is related to GERD severity. On the other hand, it can also be involved in the pathophysiology of GERD. It's very crucial, especially to diagnose IEM prior to anti-reflux surgery, as post-op patients may develop post-operative dysphagia. IEM, in fact, is also highly prevalent in conditions with smooth muscle disorders, for example, scleroderma, other forms of connective tissue diseases, gastroparesis, and also Parkinson's. However, it's not more common in diabetics. There are, in fact, some medications that may affect the diagnosis of IEM, for example, skeletal muscle relaxants, phosphodiesterase inhibitors. On the other hand, calcium channel blockers, nitrates, opioids, anticholinergics, they seem not to affect the IEM diagnosis during manometry. Several studies do show that there is no correlation between IEM and esophageal symptoms. However, it is definitely associated with an abnormal esophageal reflux burden, and this may definitely affect pre-op decision. Ideally, it's best to perform MRS or multiple rapid swallows 3 times to demonstrate the esophageal peristaltic reserve. IEM, in fact, does not progress over time, and quality of life does not seem to be much impacted based on a paper by Ravi et al. On the other hand, the presence of peristaltic reserve during MRS confers a better prognosis and efficacy in their response towards prokinetics. Overall, it's quite challenging to treat IEM because there's no clear delineating line on when IEM patients require treatment. There is no form of pharmacological agent that restores the esophageal smooth muscle contractility or improves symptoms. Diet and lifestyle modification is quite crucial, especially in those who are obese. Conventional prokinetics, for example, metoclopramide, domperidone, do not seem to be beneficial in IEM. If the patient has GERD as the main symptom, definitely the treatment of GERD is very crucial as part of IEM management. PPI treats the reflux and the reflux-related symptoms. However, it does not improve the esophageal motor function. Well, there are some evidence that mentions on prucalopride, where prucalopride enhances the amplitude of primary esophageal contractions in GERD. It also decreases the esophageal acid exposure and promotes gastric emptying. Azithromycin, a motility receptor agonist, is also effective in IEM, whereby it reduces the esophageal reflux exposure in GERD. Based on this paper, they recommend an algorithm in making a decision for prokinetics in IEM. If a patient has mainly esophageal symptoms, for example, refractory GERD, we perform a manometry. And in the manometry, if it shows evidences of esophageal hypomotility, for example, IEM, thus prokinetic is warranted. On the other hand, if a patient undergoes manometry for any indication and we find IEM as part of the findings, we assess what are the esophageal symptoms really are. If there's very high likelihood that these symptoms are IEM related, for example, GERD and dysphagia, therefore prokinetics is warranted. On the other hand, if the likelihood of these symptoms towards IEM is low, therefore the patient only requires symptomatic treatment, not prokinetics. Prokinetics, in fact, targets the distal esophageal peristalsis, mainly the smooth muscle region. Important to note that this area, in fact, is controlled both by central inputs and also the enteric nervous system in the esophageal wall. Dopamine 2 receptor blockers, for example, metoclopramide, domperidone, are quite a potent prokinetics. Metoclopramide augments the esophageal contraction in healthy volunteers, but however, it's not that beneficial in IEM. Important to note also that they do have side effects. Domperidone causes prolongation of QT intervals. Metoclopramide does cause extrapyramidal side effects. Serotonin modulating agents, for example, buspirone, is effective in scleroderma-related esophageal dysmotility. However, it's not effective in IEM. On the other hand, prucalopride is a enterokinetic agent. It does not possess cardiac toxicity, and in patients with GERD and IEM, a single dose, in fact, enhances the primary and secondary peristalsis. Motility receptor agonists, in fact, for example, erythromycin falls under the category of macrolide antibiotics. It stimulates the motility receptors on the smooth muscle fibers and thus improves esophageal and gastric motility. On the other hand, the disadvantage includes risk of inducing microbial resistance, tachyphylaxis, and also prolongation in the QT interval. Other forms of prokinetics, for example, the muscarinic receptor modulating agents, Bethanechol is one of the examples in this category. It directly acts on the muscarinic receptor. Thus, it increases the LES pressure and improves the esophageal peristalsis. The side effect includes causes nausea, somnolence, and also increased in urinary frequency. Well, as a whole, patients with esophageal symptoms related to esophageal hypomotility, we can broadly split them into two arms, whether if it's GERD predominant symptoms or if it's non-GERD predominant symptoms. If GERD is a predominant symptoms, we optimize the treatment for GERD. As the treatment is being optimized, if the patient's symptoms does not respond to the GERD treatment, therefore we can consider adding prokinetics. The first line would be prucalopride. Second line, for example, pyridostigmine Bethanechol. Third line would be a short course of erythromycin. On the other hand, if the non-GERD symptoms predominates, we assess regarding the severity of the esophageal symptoms. In patients with severe esophageal symptoms where they have severe IEM, thus prokinetics can be considered. That's all for our discussion today. Thank you very much.